Good afternoon. Hello. Welcome to the third presentation of the fall 2015 season of the Medical History Interest Group. I'm Bob Palesher. I'm on faculty in the College of Allied Health here, and I'm a member of the advisory committee of the Medical History Interest Group. The presentation is sponsored by the Loftus Library History Collection and Department of Bioethics and Interdisciplinary Studies. If you haven't already done so, please sign the attendance sheet. We will find you. Future presentations. On Monday, November the 9th, the presentation is Dr. Anton Chekhov and the syphilitics of Sakhalin Island, and will be presented by John Papalis, MD. Today's presentation is the history of amputation, Dr. Robert Liston, anatomy, dexterity, and amputations. Our presenter is Carolyn Horne, PhD, Master's in Science Nursing, Assistant Professor in the College of Nursing here at ECU. Carolyn's been here for about 5 years. She admits to it. Our exhibits. Currently, we have a traveling exhibit from the National Library of Medicine. It's called Pick Your Poisons, Intoxicating Pleasures and Medical Prescriptions about Tobacco, Marijuana, Opium, and Cocaine. It's here on this floor. Also on the far wall is The Essence of Caring. It's part of Loftus Library's Arts and Avocation series. Here is Carolyn Horne to speak on the history of amputation, Dr. Robert Liston, anatomy, dexterity, and amputations. Carolyn.
Thank you. Well, I want to thank the Medical History Interest Group for inviting me. This is an interesting subject to me, probably not to some, but to me it's very interesting. It also is a great week to do it. We'll see Dr. Liston was born this week, plus it's Halloween, and for some reason they always want to put Halloween with amputations, but it really doesn't have anything to do with that. So first I wanted to point out, and this was the slide, this kit that we used actually, and Melissa had the picture of it. I told her I wanted this one on the announcement because I had seen this kit here in the library. It was on display at one time, and I immediately walked up to it and knew it was an amputation kit when I saw it on display. So she had the picture, and you can find it actually at the Country Doctor Museum, which is near Zebulon, and this one is about circa 1898 that they use. And of course, everybody knows what the saw is for in an amputation kit usually, but the knives are what they use to cut through the other, the tissues, the muscle, and they probably, underneath that saw, probably is a bone nipper too, that they use to nip the bone back with when they were doing amputations. But our era that I'm going to be talking about is actually a lot earlier than when this kit was used. They used some of the same materials, but not specifically a kit like this. So when today, what I wanted to discuss was the surgical history of amputation. That is where my roots come from. I'm a nurse by trade, by profession, and I have worked in vascular nursing for many, many years. And I worked at the hospital here in Greenville, and I took care of the vascular population, which included a large majority of the amputations done at this facility that the vascular surgeons did. This was the population I serviced. I've worked with them for many, many years. And so that's how I became interested in it. And my dissertation was related also to amputees and their pain. So it is something that I've done for many years. I've been a nurse for 32 years, and have recently become a faculty for the last 5 years. But I'm going to explore the amputation history related to surgery from early ancient evidence on up to the Georgian and Victorian era in British history, actually. And then I'm going to review Dr. Robert Liston, who is an anatomist first and then a surgeon, and his contribution basically to amputation surgery. So early evidence, what we have found is in the Upper Paleolithic era, we found archaeological evidence, usually surrounding the Neanderthals and their skeletons, which was about 45,000 years ago. And what they first found was there was someone or a Neanderthal missing his upper limb. And they thought that it wasn't by chance or malformation. It looked like it had had a clean sort of surgical removal. So that was where they first found evidence that amputations were dated back to that era. What we did find that long ago, up until around Hippocrates, is that we found that most of the amputations were not medical. They were done for spiritual reasons, they were done for ritualistic reasons, or punitive reasons. If they convicted someone of being lazy, usually they would cut off their foot. If they convicted somebody for stealing something from another, they would cut off their hand or their arm. So that was the reasons amputations were done during this period and not really due to a medical related reason. And then we saw in cave paintings around 36,000 years ago missing limbs in these paintings, but not really sure of the stories of why they were missing their limbs, but there were people in these paintings that missed their limbs. So then we go into early evidence of prosthetics. And this, I'm going to say a little bit about prosthetics, but prosthetics has a history of its own. And it normally mirrors what's happened with amputation surgery, but it's got another history related to that I didn't want to delve too far into. But between 3500 and 1800 BC, the Rig Veda, which is an ancient Indian collection of Sanskrit hymns, was written. And in this text of Hinduism, they talked about the warrior Queen Vishpala. And the warrior Queen Vishpala was a woman warrior. She went to battle, and in the battle, she got an injury to her leg. She went, had an amputation done, and then they quickly made her a prosthetic out of iron in order for her to return to battle. And this is what this hymn has talked about, and how she made it back to battle with this iron leg. And then approximately 1000 BC, they unearthed a prosthetic. And this is the oldest prosthetic that they have unearthed. And this was a wooden hallux or a big toe. And it was found with on a mummy that was buried in the west bank of the Nile. So we know that amputations were being done during that period also. But what we do know is Hippocrates is the father of medicine. We have, if you're medically related, we've all heard of Hippocrates. And he was 460 to 377 BC. And his earliest writings were on therapeutic amputation. And it was called De Articularis for vascular gangrene. Hippocrates believed in amputation for gangrene only. And this will change as we go through history, but he really felt like gangrene was the only reason to do it. And the only reason he felt like it should be removed due to gangrene was after a battle. He really thought that if they sustained this gangrene from battle, then we should do amputation. If not, maybe we should wait it out and see what happens. He actually, in his procedure, how he performed amputation was he only cut away the bad tissue or the infected tissue. He did not believe in messing with the tissue that was viable, healthy, but he would just cut through that unhealthy tissue. Or if it got real bad, he said that you could cut through the knee, but he didn't like to cut through the knee. And what some believe is that his amputations, cutting through the unhealthy tissue, was more like a debridement, like we know today, just taking the bad tissue out and leaving everything else alone, and then trying to work with the tissue. He also believed in cautery and ligatures to stop the bleeding. Prior to Hippocrates, the way that bleeding was stopped, which some find very shocking, is that they would do an amputation and then they would take the residual limb and they would stick it in boiling oil to cauterize it. So prior to this time, that's the way that bleeding was stopped when an amputation was done. So he brought some more humane method to it, but as you'll see, that changes too over time. He also believed to use boiling water for cleansing the wound after amputation, and he did recommend hand and nail cleansing, which is some of the earliest aseptic techniques we read about, which is also something very prevalent in hospitals we're talking about today, is hand cleaning and infection. So he talked about all that way back then. His healing was secondary intention. And what I mean by secondary intention is that he believed in doing the amputation and then you put a dressing on it and let it heal the way it is. There was no suturing the tissues together. There was no bringing the tissues together. It was just how it healed was how it healed back then. And in order to do that, usually they had put some form of dressing on it with various concoctions or poultices that they used in order to help the healing process. Of course, you can almost guarantee that there was a high mortality rate due to hemorrhage or sepsis, infection. The people, if they made it through, may die a week, 2 or 3 weeks later due to the infection that usually took over. In this picture, I wanted to sort of put that up there. They are doing an amputation. It's a caricature of an amputation. And what I wanted to point out was the pot with the yellow flames in it. This is what was present in the operating area because they didn't have, operating rooms or theaters at this point in time. But this was present, and what they would do is they would stick the cautery irons in there in order to do the cauterization of those bleeding vessels. And these are some of the pictures of what cautery irons look like, and there usually were a number in that vessel of fire that they kept near the table. And they would just, as they found something bleeding profusely, they would get one of those irons out and put it to the tissue and let it sear and close up. And he also used ligatures, which was something that was newer during his time. And a ligature is just where they tie off a vessel. They usually tie it off and then ligate it or cut it, what we call ligation of the vessel. Their materials they used for ligature was not sutures like we know them that are sterile, but they're usually a piece of thread from a fiber, a cloth, or horsehair they would use sometime to do that ligature or that tying off of a vessel. So now we've made it up to 25 to 50 AD, and this is Celsus. He was a Roman encyclopedist by trade. But those in Rome felt like he was more of a physician because of his knowledge that he gained by being an encyclopedist. And so he started practicing medicine. And he had a little bit of change in idea of how the procedure should be done from Hippocrates. And that is that he felt like instead of just cutting the bad tissue out, you should take a little bit of the viable tissue in order to make that clean cut area. He also was the first to talk about using a flap to cover the bone, whereas Hippocrates just cut through it and how it healed was how it healed. But he felt like it should be covered and tried to use skin in order to cover the area up to close it and help it heal a little bit better. He also was the first one that talked about cutting the bone shorter than the surrounding tissues in order to bring those tissues together when you're trying to heal it. Because prior to that, all tissues came off at one level. The skin, the muscle, the bone all came off at one level. He wanted to cut that bone back shorter, and that's what we do today. So he is one of the ones that really started talking about cutting the bone shorter. For bleeding, he also used cautery and ligatures. Cautery basically for the larger vessels in the limb, and then he used ligatures for the smaller vessels with some compression. Usually one of the assistants would compress some of the vessels that were bleeding to try to get them to stop while the procedure was ongoing. He also believed in asepsis, and the way he performed his asepsis was he packed the wound with a lint cloth soaked in vinegar. They really felt that vinegar had healing properties and that the vinegar would help to keep away the infection. But yet his mortality also was very high back then. When Rome fell, though, his advancement in the procedure and the asepsis all fell with him. There was he really was an advanced thinker, and then we lost it. His wonderful advancements with the fall of Rome. Archigenes and Heliodorus were 50 to 75 AD. Archigenes was from Rome, and he was a medical author and physician. Heliodorus was his counterpart in Egypt. So they were actually practicing pretty similar in their respective countries at the same time. And you'll see some of the same similarities in literature when you're looking at these two physicians. What they did is they shifted the paradigm. Before now, everybody thought you should do amputations for gangrene. When it looked bad, the tissues were bad, that's when the amputation should be done. But with Archigenes and Heliodorus, they expanded that. They said, well, we can do some for chronic leg ulcers that aren't healing. Cancer was a big thing that they had begun seeing and felt like you can do an amputation if your leg has a tumor or it became cancerous. And then some trauma and some congenital malformations also they expanded into. They were the first to use tourniquets proximally to the affected area in order to do an amputation. They also felt like that tourniquet would help to prevent some pain because during this time there were no pain measures. You had an amputation awake and alert and without going under any anesthesia. There was nothing that they used other than people holding them down on the table in order to have their amputations done. These gentlemen also believed in what some physicians practice today, and that they removed the nerves in the periphery in order to prevent some of the pain after the surgery. So this was the first ideas of that occurring, and we do some of that today also. They also used ligatures for the large vessel and compression and torsion for smaller ones. And the torsion was just, they had compress it and they had twist it in order to get it to stop bleeding. They also felt like cold water, if you poured that on there, would also sort of do vasoconstriction of those vessels and help them not to bleed as much. And so they utilized that during surgery also. Their healing was achieved usually with poultices or dressings afterwards that were made of various and sundries of things, some being leeks, bread, salt, astringents. And so there were a number of things they would try in order to heal. Galen, who came along about 131 to 200 AD, he also believed in amputations for gangrene and cancer. He felt like he went back to Hippocrates and said, you can only cut the non-viable tissue or through the joint. You don't want to mess with the viable tissue. So he sort of differed than Celsus on his thought process and sort of went back to Hippocrates and what he felt. But the thing that he actually did was, in his cancer patients, what he would do he would burn the roots of the tumor with a cautery. This actually was the precursor to the thermal ablation of tumors today. So he was the founder of the thermal ablation of cancer tumors that we know today. And so I found that very interesting that he was that forward thinking. Talmud is not a physician, but Talmud is writings that I wanted to put in here for you to sort of understand further expansion of the causes of amputations. And this was between 200 and 500 AD. And they are rabbinic Judaism writings. They came from the Babylonian region, usually. And in these writings, they included leprosy for amputation, as well as incurable infections for amputation. And this was the first mention of sedation for surgical procedures. They mentioned it. There wasn't a whole lot of expansion on that, but they felt like there needed to be more sedation of the patient in order for them to have this type of surgery. Now let's get up to the Dark Ages. And this is around the Middle Ages. We're 700 to 1400 AD. And this was a bad time for surgery all around. It was a bad time for amputation surgery, but all kinds of surgery. It was horrible. There was no advancement in practice. There was nothing seen during this time. They still felt like leprosy, you could amputate, but they also included ergotism. Ergotism actually became very pandemic around 850 BC. And what ergotism is it's a poisoning due to the fungus that is found on rye and other grains. And in this picture, this is a rye or wheat, and this is the normal stem, but this is what they call an ergot. And that ergot is a fungus, and it became very lethal for a lot of people. And where this poisoning, why it became so pandemic, was because it was a very poor time. And they would make bread and eat a lot of bread. And with this eating of bread, they didn't understand what this protrusion was from the grains that they would harvest to make the bread. So that would be included in the meal that they used for the bread. And it was this that was causing the infections that all the physicians began to see. And this ergotism usually infected the hands and feet. They became very dark. It almost shut down the vascular system. The hands became black. The feet became black. They would try to amputate in order to save them. It was almost a fatality, though, if it spread into other vascular areas of the body. One of the vascular areas that this ergotism affected too was our mesenteric artery, which supplies our stomach area. And this, when they had ergotism in their stomach, it was fatal. There was nothing they can do, but it was very, very painful to the patients that were experiencing this. It became so wrapped up in the Dark Ages with this ergotism infection that they actually had a patron saint of ergotism, or holy fire. And the reason they called it holy fire was because of the pain that it inflicted on these people that had ergotism. So let's move on through the Dark Ages. You want to get out of the Dark Ages as much as you can. And let's go to 1100 to 1250 AD. This is when the Catholic Church came in with a decree during this time. It was not, and it bounced us back even more from our surgery and amputation surgery. And they prohibited bleeding by their decree, the Catholic Church. So guess what this did for surgery and surgeons? I mean, this is what surgery and surgeons do. They cause bleeding. And so the Catholic Church says we don't look favorably among surgeons nor surgery during this time. So the surgeons did not want to be seen as unfavorable in the eyes of God, so they decided they weren't going to do surgery. So surgery changed hands during this time, and surgery changed hands to barbers. And this is where the term barber surgeons came from. The barbers, who were the people who cut the hair, were very skilled with their knives, so they felt like they could handle the surgery, and they were the ones that started doing all types of surgery during those eras. But the skills deteriorated by the surgeons not using the skills that they had and not honing in on those skills, and patients suffered usually by it. Lots of patients died during this time, and it was just a real dark time for surgery and surgeons as a whole. So the end of the Dark Ages, between 1300 and 1400 AD, There was a change in war methods. Prior to this time, most war was related to stabbings, piercings, that's the main injury mechanism. That's where the infection would come from. But in 1346, at the Battle of Crécy, cannons were introduced. And with these cannons and the shooting of cannons, fragments of metal became breaking off. And then just 20 years later, at the Battle of Pyrgai, there were muskets introduced. So you can imagine we're going from stabbings and piercings causing injury and infection to now metal fragments causing infection, as well as, with muskets, shattering of bone. So now we've come into shattering of bone with our battle, and which caused more battle injuries and more amputation. So let's sort of get out of the darkness, out of the Dark Ages, and into the Renaissance between 1450 and 1700 AD. We came back into practice of surgery. This was a time that they needed in order for advancement of all types of surgery, including amputation surgery. The printing press came into play at this time. That made it easier for us to spread the word about how to do surgery a lot easier, because they would do printings of Hippocrates, Galen, Celsus, handwritten journals on how they did certain types of surgeries, and they were able to distribute these. So surgeons got a lesson in what was acceptable prior to the Dark Ages at this time. They rediscovered the cutting the bone shorter at this time. With barber surgeons, it was not that well of a technique. It was almost like it was back in the early Paleolithic. They just cut and let it heal the way it needed to in the Dark Ages. In the Renaissance, we see them back to the practices that Hippocrates and Galen and Celsus had so meticulously looked at in trying to cause healing and improvement. In 1452, Hieronymus recommended doing amputations below the knee. This was right below the knee, whereas prior to this, they had just gone to where the viable tissue was and cut. So you may have some amputations that were real long, and you may have some a little bit shorter, but there was no set place that they really should be cut. He also felt like through the knee was the most proximal you should go. There really wasn't, before this time, they really didn't know about doing amputations higher than the knee level. They thought that was not a good idea, so they would not practice doing amputations above the knee level. Also, what helped us was Da Vinci and his anatomic drawings during this time. It made looking at the anatomy a lot easier when you were doing surgery. And so it was a time that actually was good for surgery altogether. Hans von Gersdorff in 1517 AD, he published the Field Book of Wound Surgery. And now we're starting to look at amputations related to a lot of battles and war. He changed the tourniquet to be more effective. The tourniquet was known before this, but it's more like a very loose bandage above the amputation site, but nothing real tight. He actually felt like it needed to be tighter to be more effective, so he started tightening the bandage a lot more in order to cut the blood flow off some more. He would actually use two tourniquets. He would do it proximal to the site and distal to the site where he was cutting. And so he would use two tourniquets. And through time, people have used two tourniquets and then they've used one tourniquet. So I found it was a matter of preference from physician to physician, basically. He also used a styptic made of egg whites for his cautery. That's the way he felt like he could stop the blood flow better. He didn't approve of boiling oil, but he said warm oil might be okay to do some cautery with. And then for his dressing, for healing, he used a pig bladder in order to keep it sanitary as could be, or aseptic as could be. So he actually had some various different thoughts. So in 1509 to 1590, we get to Ambrose Paré, and he is known as the father of amputation surgery. He really looked at amputation surgery and tried to figure out what were the best methods to do amputation surgery with. He was an inventor. He actually was the one in history that invented the modern day hemostat that we know. And this is a modern day hemostat, and he did a spring-loaded, almost like scissor back in that time in order to hold the vessels closed. So that was his means of cautery. He also looked at prosthetics, and his concern really was, in looking at prosthetics, how could he do his surgery individualized in order to make sure that they could get a prosthetic and be functional with that prosthetic, which was a different thought process than anybody prior to his time. He was very concerned with the patient and how they would do their activities of daily living after surgery. He followed Celsus in that he believed in amputation through viable tissue, and he also used a tourniquet to control the bleeding. He did cleanse his wound or amputation site afterwards with turpentine, which was big in use at that time period. They felt like that had better infection control properties than anything else. And he actually performed the first successful transfemoral or above the knee. So he had gone above the knee, which was very different than what everybody had been taught prior to then. He also was the first person to characterize phantom pain. It was not talked about prior to this period. The people that did talk about pain in the limb that was missing, he thought they were sort of mentioned as crazy, but Ambrose Paré said this was a real phenomena for patients who had had amputations, and even though he could not stop that pain, he said this is acceptable, this is what they feel. And prior to then, nobody would accept that they were having pain in the limb that was amputated or the area that was amputated. So that is one of his well-known thoughts about amputation surgery. His disuse of using boiling oil for cautery methods actually was related to his time being a French military surgeon. And what he found is that the procedure when he was on the battlefield was to use boiling oil for cautery. And so haphazardly, he ran across the fact, and this is his research, is that he ran out of boiling oil. And so he didn't use boiling oil on the people that, he had lost his supply with. And he found out by looking at the people that had had boiling oil as compared to those who hadn't had boiling oil for cautery, that the ones who hadn't had it had a better mortality rate. So from that point forward, he said, I'm not using boiling oil anymore for cautery. I don't like the practice anyway, but this really proves that, we shouldn't be using it. It's better not to use it. So for the remainder of the Renaissance, it was usually all about the tourniquet method and the cut. Prior to this period, the cut had been a one-cut process. You cut through all the tissues at one time, the epidermis, all the muscles, and then you use the saw. But with the remainder of the Renaissance, they actually said, well, it might be better to use two cuts rather than one cut. So in 1674, Morel, he first invented the true tourniquet. And that is where he had a tourniquet around the extremity and used a stick, actually, to tighten it until the bleeding stopped. Then in 1679, we first come across James Young, who actually had the modern day approach to our flap. And that is flapping the muscle and the skin over and the end of the bone in order to cut it off or to heal it better. He touted at that time it was a new approach to doing the amputation and did a book related to his new approach with amputation surgery. In 1718, Jean-Louis Petit, he is the one that invented the screw tourniquet. And this is a picture actually of the screw tourniquet. And that is where you put the tourniquet material here, and there was a screw, and you would tighten during surgery usually down until bleeding stopped. And if bleeding started, you would tighten it even further. So that was a screw tourniquet that became very prevalent throughout amputation surgery. He also is the one that developed the two-stage circular cut for amputation. He would cut through the tissue and the subcutaneous tissue first, and it would be distal to the site and pull that back. And this picture sort of shows it. And they would have assistants pulling this subcu tissue, the epidermis back. And then what would happen is he would take another instrument and cut through the muscle to the bone and use the saw for the bone. So that was the two-step process that they had come up with. Now we're up to Napoleon and his era, 1792 to 1815 AD. There were two standout surgeons, one for the English and one for the French. Dr. Guthrie was that one in England, and Dominique Jean Leray for France. They both performed successful hip disarticulations on the battlefield, and that means they took the leg all the way up to the hip and cut it off, which had never been done before. So that was the first hip disarticulations, and that was related to a battle injury. They changed the practice in battle. Prior to this, it was felt like if the person had gangrene or infection of the limb, they needed to wait 3 weeks before surgery was done. And part of the reason for them waiting for the 3 weeks was because they felt like if they could survive that 3 weeks, then maybe the amputation was worth doing. But if they didn't survive that 3 weeks, then it wouldn't go into their mortality rate either by doing that. But they felt actually, especially Leray, felt like the way we did battle and left our soldiers on the battlefield was poor taste. And so he felt like the best way to do amputation was to get them out of the middle of the battlefield where they normally did their surgery and into an aid station where they could do it under a more controlled method. So he actually, Luray, invented what was called the flying ambulance. Now, it's not anything related to flying like we know, but this is a markup of the flying ambulance that Luray invented. And this would go to the battlefield, throw the soldier in the back, and get them back quickly to the aid station, and they would not wait 3 weeks for their limb to be amputated. They would go ahead and amputate it immediately. And he actually saw a better mortality rate by doing it that way. People live through the amputation, doing them immediately and getting them to an aid station as related to doing them on the battlefield or waiting for 3 weeks to do them. So this brings us up to Dr. Robert Liston. And I'm going to close out by talking about Dr. Robert Liston. He was actually a very interesting surgeon during the time, and one I found very skilled, and you will probably see that as we're talking. He was actually born October 28th, 1794 in Scotland. His father was a minister. He is accredited for teaching him everything he knew up until he was 14 years of age when he went into the university in 1808. And that was pretty common then at that age to enter the university. He started in the university being trained in anatomy, and that was his first love, was anatomy. In 1810, he began his medical studies at the University of Edinburgh and learned under some very skilled physicians of the time. In 1814, he became house surgeon at the Royal Infirmary of Scotland. And then he moved to London 2 years later to continue his training at the Lord Hospital. And then at age of 24, which is 10 years later, he was an old man by then, and he was admitted to the Royal College of Surgeons of England. But he returned to Edinburgh, where his family was and where he had grown up, and he started working with his cousin, who's James Simi. Now, James Simi is pretty well known for doing some amputation surgery too, because we have what we deem this semi-surgery right now, and that is a cutting or amputation at the ankle level, basically. And he worked with his cousin in teaching anatomy because that was how he was trained. And then in 1818, he became a fellow of the Royal College of Surgeons in Edinburgh. And in 1819 to 22, Simi and Liston started a school. They started a school of anatomy and surgery where he taught, and he taught mostly anatomy at that time. But he and Simi had a falling out. They got into a disagreement, and he left the school. And up until that point, he had done all his operations in the Royal Infirmary. He taught in a school, and he'd go to the Royal Infirmary and do operations. But when he got into the disagreement with Simi, he was banned actually from the Royal Infirmary. They told him to get out. They didn't want him back. I think he had made probably some people very unhappy in the Royal Infirmary. And part of it was because he always operated on those less fortunate or those that other surgeons would not operate on. He felt like everybody should have a chance if they needed surgery. So he continued to operate, but he would go to the homes of his patients during that 5-year ban and operate. He was known during that time as a very bold and daring surgeon, They continued to follow his practice and what he was doing in the homes, but he couldn't do it in a controlled environment. He had a notable removal of a large tumor of a gentleman out in the community, in which he had a large scrotal tumor measuring 42 inches and weighing 44 pounds. And so Dr. Liston felt that he could remove it without any problems. Now, it's purported that he removed it. There was a big bloodbath because it was very vascular, and there was blood everywhere. The patient slipped off the bed that he was on, and what happened next was they thought he didn't have a pulse, but the report is they gave him a pint of cordial and that he revived, and he lived, and he was okay after that, and was well. It was these types of surgeries that Dr. Liston did and nobody else would even touch during that time. So he became so notable with the surgeries he did and the successes in them that they invited him back to the Royal Infirmary in 1827. And in 1833, they had an opening for professor of surgery, which he applied for. The other contender was his cousin, James Simi, and his cousin got the position, which irritated Robert Liston, and he really didn't want to continue his practice there in Scotland, even though he grew up there, and he became very argumentative and very disliked by a lot of his peers at that time. So he went back to England. In 1835, he took a post of a professor of surgery at the newly organized University of London Hospital. And in 1840, he was nominated a member of the Council of the Royal College of Surgeons in London. Now, Liston, I'm going to talk about some of his attributes right now. And he wrote 2 books, actually, in 1837, related to his surgical practices. And one of them is called Practical Surgery, and the other is called Elements of Surgery. And they can be found in the literature, and it's very interesting reading when you're looking at them. But he was a very tall man, and he had very large hands, and his dexterity in surgery is well known. They said his dexterity is unequaled by anybody else in history, or probably will never be equaled. And part of his dexterity was related to his training in anatomy. His anatomy was so astute because of what he did as far as becoming an anatomist and working on a lot of corpses, that he could almost do a surgery with his eyes closed, knowing the anatomy so well. But what he cites in his book that came out of his practical surgery book is the different steps of the process must be studied carefully so that it may be performed dexterously with the least possible pain or risk, and in such a manner as to restore the patient's comfort and power of exertion. They felt during that time that the only pain control that you can have was speed and dexterity, to make it quick and over with as soon as possible in order for the person to have the least amount of pain. So he was very well known in being dexterous, and that helped him with his pain control with his patients. He also was very concerned about aseptic technique. Some have said he was a clean surgeon. In his book, he's quoted as saying, "Too much care cannot be bestowed in washing the sponges, removing gritty matter from their surface and squeezing them dry." because remember, they didn't have, new sponges with every case. They would use the same sponges over and over and not wash them. So him saying we need to wash them out was actually a step forward in aseptic practice. He also didn't believe in using all those poultices, all the leeks and everything else that people had used. He just felt like clean cold water was probably the best thing in order to use as a dressing, and he said changing it often actually was the best practice. In fact, during the first 24 hours, he would have his assistants change those dressings every 10 minutes with cold water. So that's how often he was having it done. We don't even do every 10 minutes today. We do maybe every 4 hours. And then his surgery technique. This I found very interesting because there were a number of assistants that they used in the operating theater. And so he says, the limb may be supported and its position varied to a certain extent by an assistant, but it must be trusted entirely out of the hands of the surgeon himself. An assistant, if there be several, stands on each side of the patient. One secures the temporary suppression of the circulation. Another is prepared to hold back the soft parts, and he's talking about the tissues. And then a third and fourth hand the instruments and sponges to the operator, whilst another tries to strive and reassure the patient and administers cordials if they be necessary, because that was their pain control. It was either comforting or alcohol, and which I found the display that we have very interesting in that it talks about the use of alcohol as far as picking your poison. And this was the poison that they used in order to give some pain relief during Liston's time. But that will change. Surgery speed was important, and like I said before, it was related to pain. The quicker that he could do it or a surgeon could do it, the least amount of pain the patient would have. He was dubbed the fastest knife in the West End being that part of England in which he lived, basically. And he had a limb amputation of 28 seconds, was his first speedy limb amputation. And this was, his way of administering basically anesthesia. He also felt it improved the survival rate, the least amount of time that you're in surgery, which is probably some truth to that even today. And he is well known for entering the operating theater and saying to his audience, because usually there was an audience, "Time me, gentlemen, time me." Because he was well renowned for his speed. Now, he's got a few infamous cases in the literature that are very interesting to read about. The first one was his very first amputation. He did in 2.5 minutes, so it's a leg amputation, but he also removed the testicles of the gentleman in which he did the operation. His second infamous case related to an amputation was that of a gentleman in which he had a 300% mortality rate in this case. Now, how do you get a 300% mortality rate in the case? And that is because the patient died due to sepsis after the amputation was completed. He cut off the fingers of his assistant during the operation, and his assistant got gangrene and died. And then a surgical spectator, another physician, was in the operating theater around the table when he was doing the operation, and while he was cutting through the tissues, he pierced his genitals with the knife, and the surgical spectator fell, and he died of shock related to being pierced by his knife, by Liston's knife. So those are a couple of his infamous cases that we hear about today. But he was a compassionate surgeon. He really was. If you read some of his notations related to his surgery. He was a champion of the poor and extremely sick. And he wrote, "It is of the utmost importance to attend to the state of the patient's mind and feelings. He ought not to be kept in suspense, but encouraged and assured, and his apprehensions must be allayed. If this cannot be effected, if he is dejected and despondent, talks of the great risk and of the uncertainty of his dying, it is better that the operation be abandoned, or at least delayed. If, on the contrary, he is confident in the resources of his constitution and in the ability of his attendant, and looks forward to the advantage derived from his own fortitude, then there should be no delay." So he really was concerned about the thought of the patient. If the patient was in good spirits, if he thought everything would go okay, then they would continue on. But if not, we need to not do it right now. Now, we've talked about his practice of pain control being speed and some cordials that he used. But ether came along in 1846. That was the first anesthetic that came along. And it was first used in the United States, in Massachusetts, but that same year they encouraged Liston to use it because of him being such a renowned surgeon in England. And so he used it in England in 1846 on December the 21st, where he removed a leg in 25 seconds, and Dr. Squire actually administered the ether to the patient during that time. So he's come along from speed and cordials to ether now. And he wrote a letter to those that encouraged him to use the ether, and his letter touted that it was a great thing. He writes, "My dear sir, I tried the ether inhalation today as a case of amputation of the thigh, and in another requiring avulsion of both sides of the great toenail. Use of the most painful operations in surgery, and with the most perfect and satisfactory results. It is a very great matter to be able to thus be to destroy sensibility to such an extent, and without apparently any bad results. It is a fine thing for operating surgeons, and I thank you most sincerely for the early information you were so kind to give me of it." So he really liked ether. He thought it would be great for his surgical practice as he continued on and would continue to use it, but he died a year later on December 7th, 1847, and he happened to die of an aortic aneurysm. So that is the story up to 1846 and the use of ether with Dr. Liston. And these are my references, and I will entertain any questions.
Microphone. I'm giving the microphone to people who raise their hands, and starting with the back. The reason is we want both the question and the answer on the recording. Otherwise, it's very confusing to other people. And if you haven't already signed in, I have the yellow pad over there.
Hi, Carolyn. Going back to where the Catholic Church said, we're not going to have surgeons do surgery or physicians do surgery anymore. What was the ethical issue at that point, and why would the barbers pick it up other, than the obvious reason they had the tools?
Mm-hmm. The ethical reason was because that the Catholic Church felt like if there was anything that someone did to cause bleeding that was messing with something that God deemed you shouldn't mess with, basically. You shouldn't cause that injury, or you shouldn't cause bleeding of an individual. So it really is related to a religious thing. And then the barbers picked it up because it still needed to be done. Surgery needed to be done, and surgeons took a hands-off approach. So the people would go to a barber to get surgery done because they were so skilled with their knives and using their knives for, shaving and cutting hair. So they felt like that was the closest thing they could get to a surgeon.
Any other hands?
Hi, Carolyn. That was a fantastic presentation. Thank you. So I'm interested in terms of Dr. Liston in Scotland. You noted that some of his colleagues were upset with him because he worked on the less fortunate. Was there an issue with access to amputation for the less fortunate? Like, for instance, was the folks who were, I guess, at the higher end of society had access to amputation versus the lower end of the spectrum? Yes,
and that's true. And that's why he's known of actually practicing with less fortunate or the underserved. He actually lived in a part of England at the West End where there was very high society, and they all had access to the surgeons of the day and all that. But the surgeons would practice on those influential people, but those that they felt like, were not ones they wanted to practice on, or the underserved, they would leave them alone. But Liston didn't feel that way. He felt like everybody deserved a chance, no matter whether you're from an influential family or you're from a laboring family.
Speaking of that, how would they actually pay for the surgery itself?
Well, with the influential families, usually they paid, their gold monetary. For those that were the less fortunate, he would not charge them. Those he just did the surgery out of the kindness of his heart, basically.
And did they ever talk about any kind of therapy? Like, when did that come into play? Would they have any kind of therapy afterwards to help them rehab after having the amputation?
They did not really have a lot of therapy. They would, now Liston was very proactive in looking at each individualized patient and figuring out how he needed to do the surgery in order for that person to have a prosthetic. He actually invented a prosthetic called a kneeling prosthetic. And so he was very concerned about them being able to get back up on something that they could walk with. But as far as therapy, like we know therapy today, there wasn't that. It was, you were given the prosthetic and you either got up with the prosthetic or you did not get up with a prosthetic, and it was up to you, basically.
I had a question about whether arm amputation followed kind of the same history along with all the, like, below the knee stuff you were talking about, whether it kind of followed the same trend of, like, you're talking about sterilization, the techniques.
In fact, when you're reading through the literature, usually it's the same scenario with the arm amputation as the lower limb amputation. The same sort of concerns, asepsis, controlling bleeding with ligatures or cautery. So it's the same for upper limb amputation as well as lower.